So I hope those breakout sessions were good, and I hope you've enjoyed. We tried to build in a little more networking time into the agenda this year, so I hope that's been good. This session is a new format that we're trying, so when you get your evaluation, please give us feedback. We get so many good abstracts for posters, and we like to feature some of them as podium presentations. So what we're doing today are basically speed podium presentations so that we could be as inclusive as possible in our presenters. So our moderator for this session, Anthony DeGiorgio, has been on our planning committee. Dr. DeGiorgio is an assistant professor in the Department of Neurosurgery. His clinical and research interests include traumatic brain injury, spinal cord injury, and minimally invasive spine surgery. He's also very interested in socioeconomic and policy research, specifically Medicaid policy and access to care. He's the director of spinal neurotrauma at Zuckerberg San Francisco General Hospital and Trauma Center. So I'm going to hand it over to Anthony to moderate our session.
That applause is appreciated but undeserved. Thank you very much. These will be 5-minute talks. We're going to be a little bit draconian about the time allotment because we do have to get through all these, and I want to make sure everyone gets their fair share of time. So our first presenter, Anna Chodos, is a professor. Dr. Anna Chodos is a professor of medicine in the Division of General Internal Medicine at Zuckerberg San Francisco General and the Division of Geriatrics, both within the Department of Medicine at UCSF. Her clinical work is in outpatient specialty care in geriatrics and dementia care. Dr. Chodos.
Hello, good afternoon. Wonderful to see friendly faces and future collaborators, I hope. I have the opportunity to tell you about a program we've been working on, Dementia Careware, presenting it on behalf of my team, of course. So Dementia Careware really is the result of health policy progress, I would say. So it started as a California statewide initiative as a result of a bill that was passed to expand benefits within Medi-Cal to allow for dementia screening to be reimbursed when done by trained primary care or billing providers, as they say, because there was this tiny gap in older adults where people who had Medicare had that benefit within their health insurance, and people who were Medi-Cal only, so people who are low income and did not qualify for Medicare, often because they didn't pay into the system or work in the formal sector, that they didn't have that benefit within Medi-Cal if they didn't also have Medicare. So a bill was passed, and the goal was really to improve the detection of dementia. It's often detected in the moderate to late stages. If we detect it earlier, there's more we can do for folks, both to improve the outcomes related to dementia, quality of life, and facilitate advanced care planning. So between 2022 and 2024, we were funded by Medi-Cal, a consortium of us across the state, with us taking the lead here at UCSF, to develop the screening approach, which was called the cognitive health assessment. We were required to use validated tools from the literature, and then also create an associated training and disseminate that training. So get providers to take the training to learn how to do this dementia screening. One of the reasons it's underdetected is because providers don't feel comfortable or confident in doing these sorts of assessments. And then our goal was also to support primary care to implement screening programs and improve, thereby sort of kicking off improving dementia care broadly. So we also were very fortunate that we had those sort of 2.5 years to get started, and then we're now partnered with West Health Institute to continue the program and to continue to support improving dementia care and primary care. We're kind of, what we say a lot often is we're trying to finish the sentence. So we started with screening and a really aggressive focus on early detection of dementia and primary care, and now we really want to facilitate better dementia care across the spectrum of dementia care. So what happens after screening? If you're a clinician, you can know how important this is to really have the support to provide the full assessment and care for somebody living with dementia. Just briefly, what is the assessment? So we came together with experts across the country and across the state to develop what the cognitive health assessment would be. So it's meant to be an annual assessment for people 65 and older who do not already have a dementia diagnosis. It was meant to be a quick check on cognition and function. Those are the two main pillars of getting to an understanding if the person does have dementia. Those are the criteria that are in our DSM-5 criteria for dementia. And then we added an assessment of their support system because we really wanted to emphasize upfront and early that caregivers, that person's support system is absolutely crucial. So if you were a patient to get a screen, you would get asked a question, anything change in your thinking or your memory in the last year? You would get screened with a validated tool for functional decline and cognitive decline. And then you would get asked if there's somebody in your life who helps you with your medical care or somebody that you've designated as a healthcare durable power of attorney, something like that. And then we had to, this is the most exciting part, of course, had to train people on how to bill. So that was really exciting. And then we had to also, we actually felt really passionate that wanted to flip the script. So instead of thinking there's nothing you can do for dementia, it's actually there's a ton you can do, a lot of evidence-based interventions to improve cognitive and functional well-being. The earlier, the better. So getting people to start a brain health plan after this screening moment, particularly if it's a positive screen. So just briefly about what we've been able to accomplish so far across the state, we've been able to train over 6,000 people. The majority, the light blue that you see, majority are clinical providers, have some sort of clinical role. Other folks are people in administration or in health systems who often take our training. And then we've reached many counties. As you can see, some of the gray ones are the ones that unfortunately we haven't reached. One of our primary goals was just to ensure that we put out a good training, one that people liked. So you can see some of our ratings here. The average rating for the content was 4.5 out of a 5-point scale. Overall quality of the activity was 4.5. And the relevance to their practice, 4.4. So we were really pleased that people seemed to enjoy our training. Of course, we know that what we really want to see is change in practice. So that will be my next year's podium presentation. I'm just kidding. But we do want you to follow us and hopefully keep abreast of what we're doing, collaborate with us. We are in the process of creating a research consortium to look at the outcomes. Thank you so much.
Very nicely done. All right, our next presenter is Dr. Amanda Bryson. She's an assistant professor in the Division of Adolescent and Youth Adult Medicine within the Department of Pediatrics. Dr. Bryson is passionate about expanding access to sexual and reproductive health care through practice-level interventions and policy changes. Dr. Bryson.
Okay, I'm really excited to be here on behalf of my team to share our research, Navigating a New Frontier, Clinicians' Confidence in Their Ability to Help Adolescents Access Abortion Post-Dobbs. Following the Supreme Court decision in Dobbs v. Jackson Women's Health Organization in June 2022, 24 states have substantially restrictive abortion policies in place. Presently, 2/3 of pregnancy-capable U.S. adolescents live in states that ban or severely restrict their access to abortion. Clinicians play a key role in adolescent abortion access post-Dobbs, and as such, our IRB-approved study recruited a convenient sample of U.S. clinicians, physicians, and advanced practice practitioners who care for pregnancy-capable adolescents using professional society listservs, professional networks, and respondent-driven sampling. And participants completed an anonymous cross-sectional online survey designed by the research team in the fall and winter of 2024 to assess their confidence helping an adolescent navigate abortion access post-Dobbs. Our results include 188 clinicians, 82% physicians, and 18% advanced practice practitioners, 26% of whom practice in states with post-Dobbs abortion restrictions. Physician participants were trained across various specialties, including OBGYN, about 34%, pediatrics, 29%, and family medicine, 13%. This bar graph denotes the proportion of participants who indicated high confidence helping an adolescent navigate a specific abortion situation. Confidence was assessed on a 5-point Likert scale from not at all confident to extremely confident, and participants who indicated a great deal or extreme confidence were considered to have high confidence. First, I would like to draw your attention to this red line, and you can see that for most of these situations, less than half of all physicians or clinicians, regardless of legislative environment, indicated high confidence across these situations. This includes helping an adolescent determine abortion access based on gestational age in another state, determine availability of telehealth abortion, determine the need for parental involvement in another state, how to obtain judicial bypass, estimate the cost of abortion, determine the number of appointments needed, and determine which documents are needed. Next, when comparing those clinicians practicing in states with post-obs abortion restrictions compared to those practicing without post-obs restrictions, those in states with these restrictions are less confident helping an adolescent locate an abortion provider and determine which documents are needed for the appointment, as denoted by those asterisks. Participants reported seeking information about their state's abortion laws, most often from colleagues or professional networks, followed by the internet, followed by their employees' legal counsel, and then lastly with internal resources or manuals. Our findings provide timely information about adolescent abortion access post-obs, revealing that clinicians have low confidence helping adolescents navigate abortion access, regardless of state-level abortion restrictions. This lack of confidence is concerning, giving adolescents reliance on clinicians for reliable abortion information. Future research should develop, pilot, and test interventions aimed at improving clinicians' ability to support adolescent patients access abortion post-obs. And given our finding, we feel that partnering with professional networks to develop internet resource guides for clinicians to support their adolescent patients navigate logistics of abortion access that is continuously updated to reflect the changing policy landscape could be particularly impactful. I would like to acknowledge my co-investigators, both within UCSF and outside the institution, our funding, and pay particular notice to our studies advisory board, who shared their expertise in adolescent abortion access with our team. And this expertise helped us develop our research design, our survey questions, and interpret our findings. Thank you very much for your attention, and I'm hopeful we will be able to answer questions following the rest of our presentations.
All right, wonderful. Our next speaker, Danae Horn, is an associate professional researcher in the Center for Translational and Policy Research on Precision Medicine. In 2013, she authored the book Chronic Resilience, which was a personal examination of the patient experience and motivated her to return to academia to study healthcare policy. Danae's research currently focuses on health technology, information, and resource constraints.
Hello to those that I haven't gotten the pleasure of meeting yet. Thank you to the organizing committee for inviting me to present this project. This is joint work with Abby Alpert at the University of Pennsylvania, Mark Duggan down at Stanford, and Murray Jacobson at USC. We are investigating productivity of medical innovation. Essentially, what happens when new technologies are introduced into healthcare? And we consider this question using a case study of immune checkpoint inhibitors to treat metastatic melanoma. So you can see from 1980, due to innovations in cancer screening and cancer treatments, if you look at the blue line, you've sort of had this steady decline in cancer mortality from 1980 through 2022. The one exception is melanoma. It's the deadliest form of skin cancer with a one-year mortality rate of 49%. And that's because existing treatments, namely chemotherapy and radiation, were generally not efficacious. And that changed in 2011 with the introduction of immune immune checkpoint inhibitors. So the first checkpoint inhibitor was approved in March of 2011, and ipilimumab targets the CLTA4 protein and essentially allows cancer cells to no longer evade the immune system and allows the immune system to do what we would hope it would do with cancer. A second set of drugs were approved in 2014, pembrolizumab and nivolumab, and they target the PD-1. So still a checkpoint inhibitor, but a slightly different target. Now, the clinical trials for all three of these drugs showed remarkable efficacy. So the one-year mortality rate improvements over baseline treatment was essentially between 10 and 30%. Of course, patients that participate in clinical trials generally look different from the population of patients that have cancer. So 64% of patients with cancer are over the age of 65 and have more complicating comorbidities. So we wanted to look at what happens in a real-world setting when these new technologies became available. So they have really transformed cancer care across different types of cancer. So immune checkpoint inhibitors, which I'm going to call ICIs for a little bit of abbreviation, they are now approved to treat 27 different types of cancer. And in 2022, they represented 44% of spending in the outpatient setting on cancer drugs in Medicare. And that is, by 2022, there were 7 drugs approved, but really it was just 3 drugs that were driving 44% of spending on cancer drugs. So what do we do in this project? We use a difference in differences design with administrative Medicare fee-for-service claims data. And our treated group is patients that were diagnosed with metastatic melanoma between 2008 and 2018. So before these drugs came onto the market, and then followed each patient for 1 year, their first year of treatment after being diagnosed with metastatic disease. And we have a control group because you may think that patients that are diagnosed before these new treatments became available could be different from patients diagnosed after they become available. So we use metastatic colorectal cancer as a control condition. Now, ICIs are approved for use in colorectal cancer, but much later than they were for metastatic melanoma, and only for a very small portion of patients. So in metastatic melanoma, the FDA labeling essentially says patients with metastatic melanoma are eligible and indicated to be treated with an immune checkpoint inhibitor, but for colorectal cancer, patients need to test positive for microsatellite instability high colorectal cancer, which is a small portion of patients with colorectal disease. So what do we find? We find that the introduction of these new drugs really drove costs in the outpatient setting. So patients that were treated with immune checkpoint inhibitors essentially have an increase of $100,000 in costs in the outpatient setting, and that is just slightly offset by decreases in inpatient care and hospice care. But we do find a huge substitution away from the traditional forms of treatment, like chemotherapy and radiation. So this is essentially just from the introduction of these drugs across the whole population, regardless of use, but we find a 40% reduction in chemotherapy use compared to pre-ICI levels, and a 7% reduction in radiation compared to pre-ICI levels. Now, the one thing we were really curious about is what happens to the one-year mortality rate. So I have an event study graph up there where time 0 is the introduction of the first ICI ipilimumab, and at about time 3 is when the other 2 ICIs came onto the market that targeted the PD-1 protein. And so we don't really see an impact in mortality until that 3rd year after these drugs came on the market. And so we find a 3.6 percentage point or 7% decrease in the one-year mortality rate, but due to those second 2 drugs. But for patients that had access to ICIs and used them in treatment, this essentially decreased their likelihood of dying within the first year by 26%. Now, why is this the case? Because only 17.6% of patients were using these drugs, pointing to issues with access and cost in care. Thank you.
Excellent talk. Our next presenter is Daniel Dwabis. Daniel Dwabis is a second-year student at UC Berkeley, studying nutrition and metabolic biology. At UCSF, he serves as the coordinator for the Patient Support Core Ambulatory Behavioral Health System. Daniel?
There we go. So thank you for the introduction. Yes, so my name is Daniel Dwabis, and I have 5 minutes to tell you how undergraduates like myself are currently helping extend social worker capacity here at UCSF while simultaneously increasing patient access to behavioral health care. And I'll start off with some background. So we've established that UCSF primary care providers very often refer patients for behavioral health care treatment, whether that be outpatient therapy or any psychiatric services. But despite that large need, there's a very constrained capacity currently in the Department of Psychiatry and Behavioral Sciences, meaning very limited outpatient therapy services and a 6 to 12 month wait list for new psychiatry patients. And so many patients often need care and would benefit from care sooner than is available. And so to combat this, the Office of Population Health created the Behavioral Health Navigation Team, which serves to connect patients with behavioral health care sooner outside of UCSF. And since 2021, Patient Support Core interns like myself and those you see on this slide have assisted in this process. And so as interns, we are pre-health undergraduate students who earn either an academic credit or a stipend and are badged either as affiliate employees or student clinical ones. And so next, I'm going to walk you through the process that a patient goes through when they are referred to us, to the team. And it all starts with the primary care provider creating the referral. Once they create that referral for the patient, it'll add them to a customized work queue that we have in Epic, our electronic health record. And so once that's in the work queue, our practice coordinator or social worker will go ahead and reassign that referral to an intern, that reassignment being logged in the system as a status change in the referral. And so once the intern has that referral, they'll go ahead and they'll scan the provider notes and the patient's insurance coverage so that they can then pull from a database that we keep and send a MyChart message to the patient with a list of in-network options to meet their needs. And so after that, we follow up the MyChart message with a phone call where we clarify any questions that the patient may have and address any concerns. These last anywhere from 1 minute to 30. And so once that's all done, that's our process, the intern then documents everything that happened and closes the referral, that closure also being logged as a status change. So the reassignment and the closing of the referral being logged as status changes, that served as the metric that we counted in order to log a measure of workload. And so here are the results. We found that in a 6-month period between August 2024 through January 2025, UCSF Primary Care referred 2,116 patients to the Behavioral Health Navigation Team, and of those, only 88 of those were seen by psychiatrists embedded at our primary care clinics, which meant that roughly 2,000 received resources to be seen out in the community. And so during that time period, 4 interns worked a total of 550 hours and logged a total of 1,174 of the total 8,410 status changes or work units. And that reflected around 14% of the total workflow and roughly 300 patients, averaging around 4 status changes per referral. And so because of that success, with the team's move currently to the Department of Psychiatry and Behavioral Sciences, they are adopting this PSC model to continue the work that we do and expand throughout the department. And the thing about this PSC model is that it is portable and can be implemented in other departments where undergraduates like myself and the interns you saw earlier learn patient communication skills, professional skills, and gain exposure to clinical systems while also making measurable impacts on patient care and patient advocacy here at UCSF. And we're currently doing that also in the Kidney Transplant Center, the Breast Care Center, and the Office of Population Health, among other places. So if any of you are from departments you think would benefit from PSC services, please do not hesitate to contact the director and a mentor of mine, Dr. Jeff Belcora, or speak to me and I can connect you. Thank you so much.
Giant. All right, that was an excellent talk. The Patient Support Corp is an amazing initiative. All right, our next speaker, Brandy Ginn, is a program manager of the Medical Cultures Lab and a research analyst at the Institute of Health Policy Studies, studying medical culture and aging. She currently assists with ethnographic data collection under PI Dr. Daniel Dohan, examining the impacts of social structures, local institutions, and cultural practices on experiences and decision-making for older adults living with Alzheimer's disease and related dementias. Brandy?
Real time me figuring out how to do this. Okay, I'll just stand on my toes. Do you know how to adjust it a little?
That good?
That's perfect. Time starts now. Okay. Hi, everyone. Thanks to the organizers who invited me. Today, I'll be discussing some results from our ongoing study on the experiences of aging and cognitive decline in diverse community settings in the United States. My focus today is going to be what we learned from the comparative ethnographic study about the role of support group facilitators. Our team found several instances of care partners in community settings seeking to build their knowledge, bolster their caregiving capacities, and fill their cup with compassionate guidance from leaders adjacent to healthcare and community organizations. Community leaders like support group facilitators, social workers, care navigators, and community organization leaders serve as key interdisciplinary consultants and serve as navigation needs by connecting care partners with resources and opportunities for education, respite, emotional validation, peer connection, and referrals to additional support. The questions that have guided our analysis about the role of support group facilitation are: what needs are met and unmet for care partners seeking guidance through support groups, and what is observed ethnographically during support group interactions over time? Okay. So the image above represents the process of care partners receiving valuable guidance from support groups in order to meet all the psychotherapeutic, informational, and problem-solving needs that arise while caring for someone living with ADRD. One distinct finding that arose across our observations were the interactions that were enabled by well-balanced facilitation of support groups. Support group facilitators provide these drops of wisdom and guidance by enabling connections, leading problem-solving discussion, and sharing applicable resources. An example of group facilitators filling the cup of care partners occurred during a meeting last October, recounted in a field note from a researcher on our team. One care partner, Matthew, shared challenges transferring health records for a loved one living with ADRD that relocated closer to him. The skilled facilitators linked Matthew's active sharing with a similar situation encountered by care partner Ruth, who shared her trials many months prior to Matthew even joining the group. So in addition to their individual expertise, support group facilitators in particular offer decision-making consultation for care partners by facilitating educational shares for newly navigating care responsibilities, and then, when appropriate, guiding group conversations into collaborative problem-solving sessions, where other care partners who have gone through similar experiences are transformed into the role of key consultants for dilemmas of all sizes. Support group facilitators, through their continuity across support group sessions, enable a knowledge scaffolding that can be accessed by care partners at different points. Okay, so this quote comes from a group facilitator named Stella. She had a long history of attending support groups prior to leading them. When reflecting on the experience of support groups and the value of attending them, Stella shared this: "I don't know what I would have done without the support group. Support groups really support you because unfortunately doctors, unless they are trained geriatricians, don't know anything about senior health matters. So caregiving becomes, as we say, we know more than the doctors, our collective, the support group." While many of us here know that doctors of any specialty don't have the time and capacity to engage holistically with their patients or care partners of their patients, as much as one would like due to the constraints and their competing priorities, many care partners in the community are then left to do their own research on care practices, health record transfer, and then other tasks related to senior health matters. This means the informational needs of care partners seeking specialized support are often not routinely met by affordable resources available locally. And so I'll just quickly wrap up by connecting our findings to the broader implications. We know that well-run support groups, they work, they provide invaluable guidance, but beyond underscoring these items, care partners want improved accessibility. This was mentioned in several of the interviews and during participant observation. Accessibility also means many different things: free, easy to get to, potentially virtually, allowing respite from caring for people living with dementia in your preferred language. As a final note, most of the support group facilitators are also volunteers, and volunteerism doesn't ensure long-term sustainability for support groups. Though many of these facilitators will continue to be unpaid, the gaps felt by participants due to facilitator turnover could be mitigated by dedicating funds to training more facilitators and then allowing them to shadow what good facilitation looks like. So thank you all so much.
All right, our next speaker, Calvin Chu, is an assistant professor at the Institute for Health and Aging in the School of Nursing. Dr. Chu's research is at the intersection of behavioral development and health economics, focusing on innovative ways to increase uptake of healthcare services in low and middle income countries. Previously, Dr. Chu worked for Innovations for Poverty Action in Zambia and the Health Economics and Epidemiology Research Office in South Africa on research in maternal and child health and HIV, respectively. Dr. Chu.
Great. Thanks, everyone, for your time today. This is joint work with Peter Hangoma at the Michelson Institute in Norway and the University of Zambia. So in rural Zambia and in sub-Saharan Africa more generally, a lot of women struggle to deliver at healthcare facilities, and that leads to high maternal mortality. So there's lots of different reasons why that happens, but one of them is that there's strong financial barriers to facility delivery. So for example, in rural Zambia, people have to bring all their delivery supplies, and even though I've done this for many years now, it still shocks me to think that a woman has to bring their own disinfectant, bed sheets, all of that stuff that you have to bring in order to get proper treatment at a health facility. And that stuff adds up and it's expensive. So the financial delivery supplies and the transportation adds up to something approximately 25% of monthly household expenditure, which is a lot. So even though care is nominally free in the healthcare system, there's a lot of these other hidden and explicit financial costs that restrict women's access to healthcare delivery for facility delivery. So savings groups, which is this photo here, represent an opportunity to finance delivery by leveraging community altruism and existing funds. So these savings groups are extremely common in low and middle income countries, and how they work is it's just a group of people in the community meeting together to do savings and loans. So think about these rural communities where you don't have mobile money, you don't have other formal banking systems. You just have all these people gathering twice a month using that locked cash box. So you see that cash box in the middle, there's two padlocks on either side, and you have different people keeping the keys, and that's how they do banking, essentially. So what we're trying to leverage here is this existing social infrastructure of a community savings group, and specifically the social fund component of these savings groups. So typically with a social fund, when someone in this community has a funeral or has other needs for healthcare emergencies, the savings group is willing to take money out of this cash box, which is basically the community savings, and offers it to people for their own expenditures. Now what we're trying to do here is to encourage these savings groups to expand the eligibility of the social fund, not just for funerals, but extend it to maternal health as well, and to have people offer money for pregnant women, pregnant members of the savings group to access money for facility delivery. So this was previously piloted for feasibility over 50 groups, and it worked quite well. So that's why we embarked on a large-scale randomized evaluation across 400 villages to test how this works. So specifically, this was a cluster RCT across 474 savings groups evaluating the effectiveness of the encouragement intervention. So at each specific savings group, what we did was we encouraged the savings group to provide maternity grants to pregnant women. So the rationale is quite similar to a baby shower that already exists in these communities. And what we convinced people to do was, instead of giving money to a baby shower, which happens after birth in these communities, try to shift the resources intertemporally and have them offer these resources to pregnant women before delivery, because that's actually more effective in terms of health outcomes for the pregnant women. So we had a lot of different data collection rounds to figure out how this would work. First, we did a baseline survey among all savings group members to measure each person's private preferences. So we wanted to know, okay, we hypothesized that the community is altruistic, but exactly how altruistic are individuals themselves? So we did a baseline survey among each member to see what they would privately want to do. And then afterwards, we had these groups of 20 to 25 people to convene as a group and discuss their preferred maternity grant amount, if any. And this was audio recorded and transcribed, and we can analyze this going forward, and this is quite exciting. And then in these sub-treatment arms, in addition to the organic group discussion that we allowed people to have, we also randomly did these behavioral information interventions where we experimentally revealed what the averages were from people's surveys. So we tell you in the private arm, on average, among the 20 to 25 people here, you prefer, let's say, a $20 maternity grant versus a $25. So that way we explicitly clarify any misperceptions or confusion over what people privately wanted. And then separately, as a mechanism test, we did the same thing publicly, where instead of the experimenters revealing this, we got people to go around a circle and publicly declare their preferred amount. So what's interesting here is you see herding effects and people sort of conforming to social norms, and then they'll say things that are different from their surveys to test the hypothesis that maybe herding is affecting their answers. So what we did here was we have our self-administered survey. We measured the value of the maternity grant at the savings group level at the end of each of these sessions. And then we did follow-up surveys prospectively over 18 months to track pregnant women and see whether or not they received the maternity grant and whether or not they delivered at the facility. So some very preliminary results here. What we found, which is quite remarkable, I think, is universal take-up of maternity grants. So I think from a policy perspective, this is quite interesting because it's zero external injections of financial resources, and that these grants were very well received, and it's correlated with altruism and positive reciprocity. So and analysis of follow-up surveys is ongoing and will confirm the receipt of the maternity grant and examine impact on health outcomes. So there's a lot more to come, and please feel free to email me and talk afterwards about this. Thank you.
All right, and our final speaker is Krista Harrison. She's an associate professor in the Division of Geriatrics and the Philip R. Lee Institute for Health Policy Studies. Her research aims to mitigate suffering associated with aging, dying, and grieving by improving policies and models of hospice and home-based care for people with dementia and care partners. For example, she uses quantitative data to examine population-level needs and generates qualitative and mixed methods data to inform the development of policy recommendations or geronopalliative interventions for community-dwelling people with dementia and care partners. Dr. Harrison.
Thank you so much. So this study aimed to think about the problem that in the United States, access to the Medicare hospice benefit requires a doctor or clinician to attest that they would not be surprised if you died within the next 6 months. And the challenge with dementia, and particularly people who are living in the community setting, so not in a nursing facility or assisted living facility, is that it's very difficult to guess whether or not somebody's within their last 6 months of life. In prior research, we've been basically as good as a coin flip in guessing whether somebody is in that last 6 months. And while in other parts of my research, we are trying to change the system because we hear from caregivers that they either receive hospice too soon and get discharged alive and they feel abandoned, they have to muddle services together, or they get admitted in the last few days of life, and it just doesn't have as much benefit as it could. So for this project, I was able to collaborate with Dr. James Deerdorf, who's in the back of the audience, and through a grant, an R01 from NIA to Dr. Alex Lee and, Say Lee and Alex Smith, they created an index that looked at mortality rates at 1, 2, 5, and 10 years mortality among community-dwelling older adults. And the C statistics show you that basically, these are between 70 and 80% of the time they accurately discriminate people who are likely to die within these specified mortality risk times. And so this model exists. It's in e-prognosis for those of you who are clinicians who are looking for evidence-based methods to support your recommendations. And I asked, well, could we replicate this for the problem of people who are looking to gain access to hospice with a 6-month mortality outcome? So we used the same methods they used in the original study. We used 2 nationally representative surveys, the Health and Retirement Study and the National Health Aging and Trend Studies. We included people who were age 65 and older, who had dementia using algorithm developed, the Wu-Glimor algorithm, and who were living in the community. Some of the predictors included age, sex, smoking status, ADL dependencies, and we looked at the outcome of death within 6 months. We used the Cox proportional hazard regression analyses to look at these outcomes. And what we found that relatively few people in these large community-based samples actually died within 6 months, so it was a little tricky to test this. We did find that the first sample is the internal validation group in the HRS sample, the second was the external validation, and the last was a temporal validation with newer data since the original study had been conducted. And despite the fact that we found relatively small proportions of population who died within 6 months, we were surprised at the accuracy of these, or the discrimination ability of the metric. You'll see in the far left column the time-specific area under the curve that C statistics is still above 0.7. So when we looked at the discrimination and calibration plots, there's really a strong alignment between the observed and the predicted risk. So here, the HRS sample is in the blue, the NHAD sample is in the red, and that's really what we'd be looking for in a traditional examination of the predicted risk. But on the other hand, when we look a little more carefully, it's very specific, but it is not sensitive. So it will accurately identify the people who are likely to die within, or if for somebody who's likely to die within 6 months, it will accurately identify them, but there's just not a lot of sensitivity, particularly at higher risk thresholds. And we had tried this model with a couple different identifying new measures, trying a sicker population, and we just couldn't get it much better than this. So in the end, what we found is that this really can only be used as a screening tool, say by an Office for Population Health, to identify people who might be candidates for palliative interventions that have a low risk of harm and a high risk of benefit, such as discussing goals of care, plans, needs, or potential opportunities for deprescribing. We're really going to need to develop more sensitive prognostic models in the future to achieve the goal of having better eligibility for hospice, given the existing care system. Thank you.
Want to stay up here? All right, if I could ask our speakers to come on stage. Make you stand here while we have some time for questions from the audience. We have a good 12 minutes before the break. There should be microphone stands at either end, so if you have a question for any of our wonderful presenters, please head to the stand and I'll call back and forth. Any questions? Comments? Concerns? Do you mind using one of the microphones? It's just a little tough to hear.
Thank you. Hi, thank you everyone. I have a question for the researcher doing things in Zambia. I forgot your name, I'm sorry. I was curious if you could tell us more about the encouragement intervention and how that encouragement intervention looked like.
please. Yeah. There we go. Here you go.
Oh, great, thank you. Yeah, sorry, I ran out of time there. But essentially with the encouragement intervention, I think what's great is that the whole premise here is the use of internal resources from the community. So the idea is we didn't form these groups, right? They're not randomly formed or anything. These are existing community infrastructure, and they clearly trust each other enough in order to sort of bank together. So they're sort of community groups that already save and have loans together and do banking decisions. So all we're doing is extending their existing trust and community altruism to offer these social grants to pregnant women, in addition to funerals and other things that they already do culturally. So what we did in the intervention protocol was we worked together with World Vision International, which is the implementation partner. We got them to show up at these savings groups with a very prescribed script on how to discuss the maternity grant, how to encourage people to do it, and then got them to decide whether or not they wanted to implement a maternity grant, and if so, how much that was, because this is all their money. We can't force them to do anything. But remarkably, I think, 100% of these groups decided that they wanted to do a maternity grant, and the average maternity grant they agreed on was something like $20, which was huge in this context.
Great. Other questions?
Hi, thanks for the great talks. I'm Sarah Garrett. I have a question for Dr. Bryson. I was just wondering, regarding your findings about clinician confidence in recommending or in helping their adolescent patients navigate abortion access, how similar or different are those to what you or others have learned about clinicians' comfort navigating access for adult patients, for example?
That's a great question, and something that I've been thinking a lot about is whether this is a gap kind of regardless of age versus is this a specific gap for minors or adolescent patients. And we don't have comparative data that will help us get to that question, but I think is definitely something we're thinking about as far as next steps in our research, which the data I'm presenting is part of a larger research effort that we're doing, mixed methods study that we're planning to conduct over the coming years. So I'm taking that back to think about our next steps.
Hi, Alicia Fernandez. Thank you all for your presentations. I have a question for our young probable doctor-to-be, the Berkeley student. I think I missed what the students were actually doing, and I was wondering if you could comment on that, and then comment on in what way was that fulfilling to the students?
Yes, thank you. That's a great question. So specifically in the behavioral health team, which is the team that I'm on, interns work to curate that MyChart message with in-network options, and we also help to update the database that we keep. And so once we've sent that MyChart message to the patient, we'll then call them and notify them of that message, and often patients will have questions about whether it be insurance or the type of care they're receiving. So in that call, the intern will then explain to the patient what's going on, and very often what I've experienced is patients wanting a shorter list, so we help them sort of narrow down their options. And as far as fulfillment, it has been incredibly fulfilling because I think with a lot of other programs, it's hard to find the real impact of what we're doing as students, but with the Patient Support Corps, in the behavioral health team, and with all the teams, we're really making a tangible impact on the patient's experience and in patient care, which is incredibly fulfilling for me, and I'm sure we have some other interns here, so it's fulfilling for all of us. Thank you.
That's wonderful, and I invite you to consider San Francisco General as a site for your services. Thank you.
Will do.
I was thinking the same thing. Our neurosurgery clinic could use some patient care navigators, so.
We'll keep that in mind. Yes, we'll talk after.
Other questions, please.
Oh, look, I learned how to change the microphone height. So I have two questions for Dr. Horn. One's easy and one's impossible. So the easy question is, and way to go, Brandy, love it. The easy question is, that figure you showed was really cool, and I'm wondering if you can tell a little bit about where that came from and where the data came from it. And the impossible question is, so these checkpoint inhibitors have made a big dent in cancer mortality, and it looks like that's happening across the board. And can you tell us in the future what the future looks like for these types of treatments and general trends about cancer mortality?
Yeah, those are great questions. So which figure of the two, the overall cancer mortality or spending?
Oh, I'm a sociologist. I don't care about spending.
Okay, good. Well, the overall is from the SEER Medicare data, which is the agency that runs the registries across the country and sort of tracks cancer rates. So I should have put the reference on the slide, but yeah, that's from the SEER data, and they have great Explorer data that you can interact with. So I encourage you to go to the SEER website as long as it still exists in a few weeks, and then they also have all the historical tables that you can go back to, I think even in the 70s, but I started in 1980. In terms of immune checkpoint inhibitors going forward, so metastatic melanoma is really unique in that the existing treatments were not efficacious, and it had a big impact on mortality for that diagnosis. There's been other types of cancer where immune checkpoint inhibitors essentially have variable response rates based on, with cancer, we're moving towards precision medicine. So based on the specific type of cancer somebody has, like in the example of colorectal cancer, you have to have microsatellite instability high in order to have higher efficacy with these expensive medications. And so I think there's a lot of work going on to try to figure out who are the right patients to be getting these treatments, where we can expect the most benefit, given that not just that there's high financial cost, but these are also not necessarily easy drugs to take. They have a very long treatment time frame. They come with a lot of side effects because essentially you're allowing the immune system to run wild on the cancer, and so you can have a lot of side effects that are likened to immunocompromises and even cytokine storms. And so there's a lot of research going on about how to treat the side effects of these drugs and how to better target them across the types of cancer that we have.
All right. Dr. Spetz?
All right, I'm going to ask Dr. Harrison an impossible question. I mean, you've been looking at hospice and, these issues for quite a long time. What do we do? Right? The predictive models are like, and we have to run them to find out how well they work or don't work. But with your expertise, I'm really curious what you think some of the viable or any single viable policy strategy is. And if there is none, then that's the impossible question.
So one of the things that hospice does really, really well is provide anticipatory guidance and in-the-moment guidance about the acute dying process. And particularly for the clinicians who have been in hospice for a while, they are phenomenal at that. They are so helpful. And the reason that the prognostic model became such an issue in hospice is, of course, because we were trying to contain costs and trying to contain costs relative to what would be spent in hospital settings. But of course, in dementia care in particular, yes, it turns out some of our other work has shown that if you enroll in hospice, it does save money at end of life by preventing end-of-life hospitalizations. But on the other hand, it's not the thing that is the most expensive over the duration of illness, because of course a lot of that is just the need for hands-on care and support, often particularly as disease progresses or as needs get higher, you need 24/7 care. So in some ways, my answer is I want a great model of community-based primary palliative care that is sort of like hospice, but it's before end of life. And so you see house calls is one model, but we don't have great funding mechanisms to support the interdisciplinary team, and we don't really know how to titrate it and transition it seamlessly to hospice without all of the undue complicated financial indications we talked about in the financialization session just a little while ago. So it's an impossible answer to an impossible question of we have to take multiple routes and invest in additional demonstration models or trying other things out and think creatively about how we measure the costs of not providing great care, particularly as the disease progresses and at end of life.
All right. I want to thank our wonderful presenters for their amazing research. And of course, thank you, IHPS, Beth, Dr. Spetz, for putting this all on. Fantastic conference.